We're super excited to welcome Dr. Mahapatra to today's webinar. Thank you so much for taking the time to speak with us. Dr. Mahapatra is an internal medicine hospitalist at Aiken Regional Medical Centers and a clinical assistant professor at VCOM. He has an extensive background in clinical and translational research with contributions in endocrinology and metabolism, as well as allergy and immunology, leading to advancements in thyroid nodule diagnosis. And then during his time at Cleveland Clinic, he spearheaded retrospective studies, authored a case study on iliac artery fibromuscular dysplasia, and even organized a hospital-wide research week to foster academic engagement. Beyond patient care and research, Dr. Mahapatra is passionate about data analysis, study design, and medical education. Today, he is here to share his journey into medicine, experiences in research, and any advice he has for students looking to make a similar impact in the field. Dr. Mahapatra, thank you for joining us. We're super excited to hear from you. But before we get started, is there anything else you'd like to add to your introduction and share about yourself?
I think, Mira, you have covered length and breadth. Thank you for that kind introduction. I have also developed interest for the past couple of years in early diagnosis of lung cancer by combined biomarkers. We have recently published a paper a couple of years ago with the combined biomarkers. It's still a work in progress, so we are working on that.
That's amazing to hear. Thank you so much for adding that.
No problem.
We can go ahead and get into the questions if that's all right. We just want to start off with a general question about your field and your specialty. Can you share a bit about your journey into medicine and what drew you to internal medicine? What kind of makes it a unique and rewarding specialty to you?
Absolutely. So, since my high school, I was very much driven to the complexities of the human health when I was studying the biology. That made my MBBS a natural progression. And then I wanted to explore. So, I went to China for my medical education. Being born and raised in India, I wanted to explore further. So, I went there to have my medical education there. I completed my medical education, came back to my country. I was practicing for a couple of years. Then I further wanted to drive down into research and want to explore further. And that's what led to me to come to the United States. So in order to be here, I had to take US families, step one, step two, step three, those are the licensing exam cleared. Then I was fortunate enough to join Cleveland Clinic, one of the pioneer institute in the medical science, where I did my 3 years of residency. That is a wonderful experience that I have. During my residency, I was uh, got driven to the patient care, and what helped me solidify my interest towards internal medicine is the longitudinal care and its diversity. So you not only take care of the acute issues, you use certain symptoms, connect the dots, and then come up with a diagnosis. So you are like a detective all around. And not only that, during this time when you are connecting those dots, establishing the diagnosis and searching why, and during that time, you are also developing a bond with the patient, and again, not only the patient, patients and their family. And it's a longitudinal care that you establish, and that is something makes me take pride on, and that's what drives me to the internal medicine.
It's amazing. Can you explain what you mean when you say longitudinal care within internal medicine?
Absolutely. So what I mean by longitudinal care is when someone comes, for example, let's say has an lung infection called pneumonia. So you treat that lung infection in the hospital. Patient gets better. And our journey doesn't end there. We need to make sure that patient, when they get discharged, they're getting discharged with a proper regimen so that they do not have the same infection again. So we coordinate that care we speak with the patient and the family, explain them, then we arrange an follow-up care for the patient. So we continue that care beyond the hospital. We do follow-up calls to see how the patient is doing through our collaborative partners, through our primary care doctors. They give us feedback how the patient is doing, how they're evolving. So we kind of get involved in their day-to-day care of their healthcare and be an advocate for them.
That's amazing. Thank you for sharing. Can I also ask you to describe your role as a hospitalist and how it differs from other internal medicine careers?
Absolutely. So our role as a hospitalist is from admission to discharging patient. So our job would be coordinating care with multidisciplinary team. So, for example, let's say that we have a patient who comes with shortness of breath, found to be having an heart failure. So we will be getting our cardiology team involved for their recommendation, how to do that. And sometimes those patients may develop an kidney failure. So we'll be consulting kidney doctors or nephrologists on the board. So they'll be able to help us, but we would be the primary connecting with them and coordinating the care. So that's what is different from an hospitalist with other subspecialty. They only take care of particular part, but we take care as a whole. And then we make sure that all those elements have been taken care and then develop a great discharge plan, smoothen the things, coordinates with the specialty. Then we also have a team called as an a case management team or social worker team that addresses our social determinants of the health. A lot of the patient may not have adequate insurances or adequate support or adequate health equity to help them once they get discharged. So we make sure as a hospitalist that those things are met. Their other needs are also met along with the case manager. And once all these are checked out, then we do a safe discharge of that patient.
Got it. So would you say that a hospitalist looks at care more holistically than a general physician does?
Exactly.
Perfect. Makes sense.
Mhm.
Can you also talk a little bit about what a typical day on the job looks like for you?
Yeah. So that's a great question. So typically, my day starts around 6:30 a.m. in the morning. I get my list of patients whom I'll be following from in the day one, and then I continue to follow throughout my week. So I'll be looking at this patient charts through our electronic medical record. I'll review the notes from the previous physicians who have seen. Then I'll develop a brief comprehensive plan before I start rounding on the patient. So once I'm done doing it takes 1 to 2 hours, then I have my residents with me. So it's part of education as well. So me, along with my residents, the team would be two interns, one senior residents. So the interns will be presenting the cases to me, and then we'll be discussing together what plan of management, what the goal of the day would be with the for that particular patient. We'll go in the room, explain them, make necessary changes, and then move along to see the next patient. So typically it takes me like 2 to 3 hours in the day to do my whole rounding. After that, we have our didactics for our residents. They go to the didactics. If I am giving lecture, I'll be with them during the didactic. If not, then I'll be taking care of the other stuff, the calls from the nurses. They will be informing for their needs of the patient, will be attending those. Then in the later part of the day, we'll be also doing admissions of the patient from the emergency room. So the emergency physician will call us and discuss a patient, and we'll be deciding whether that patient would be needing an admission in our hospital or they can be managed in our emergency room and can be discharged. If they need an admission to a hospital, we'll accept them under my service. One of my residents will see the patient, present it to me, we'll discuss the plan, and we'll admit the patient and we'll follow that patient next week. Also, during the time, we'll also have some discharges every day. We'll be discharging the patient, making sure their medications are sent to the right pharmacy with the right dosing, right follow-ups. Once that is done, we'll be sending those patients home, or sometimes they may not be able to get home because they might have become weak because of the long hospital stay. So we'll be trying to transition the care to the nursing home or other rehabilitation facility. So we play a very important and unique role in the transition of care, and that is the biggest area we work on and for a smooth transition and making sure if they're not able to go home, they can go to the nursing home, get some physical therapy, and then go get back to home.
How many patients would you say that normally is that you're looking at in one day or 1 week?
Great. So our day typically starts with patient, most likely around 14 to 16 patients we have. Then we'll have 1 or 2 admissions. Then we'll have discharges. So the range remains between 14 to 18.
Okay. And then going off of that, it seems like your schedule is very involved and there are a lot of patients that you're taking care of. Would you say that your week is more structured or scheduled? Do you work regularly every day or is it more flexible?
So my week is generally structured. I'll be doing my rounds, then I'll be involved in the didactic 2 or 3 days in a week, and then I'll have some administrative meetings because I'm also leading the quality improvement initiative in my hospital along with a readmission project. Our goal here is also to decrease the COPD readmission. So I'm spearheading that project. So we'll be having some meetings on that. So these are a few other administrative jobs we do. It's most geared towards improvement of the quality. So as a hospitalist, me, my colleague all work on that.
Okay, and I know that you've mentioned didactics a few times already. Would you be able to explain a little bit of what that entails?
Yeah, absolutely. So what I mean by didactic is that our residents will have a protected time from 12 to 1:30. So during that time, we deliver academic lectures, which are scheduled a couple of months ahead, which involves any subspecialty lecture from a nephrologist or from an infectious disease, or from me as an hospitalist. I'll take some general topic. I'll do that from 12 to 1, and from 1 to 1:30, we have case discussion. So it's mostly resident-led didactics from 1 to 1:30, where residents are empowered to present the case because they have seen the patient, and they will be slowly diverging the details, and it will be more of an interactive where all the audiences will be participating, and then we'll be discussing some learning points. So that the session works like that. And then sometimes we would do board review questions because we also have to take a boards. So we prepare them as well. And I also lead the Jeopardy. So it's more of a fun learning where we make teams and then we make questions on different topics and then we score them. And this is fun. It sometimes gets competitive, but it's definitely fun.
That's very helpful. Thank you. I know you mentioned earlier that you take part in a quality improvement initiative. Can you talk about what that entails or a little bit more about that initiative?
Yeah. So our hospital, I'm involved in our readmission committee. So this is a nationwide challenge that when the patients are discharged, they sometimes comes back within 7 days or within 30 days or within 90 days. So when it comes back, so it's on the hospital responsibility, and we have to figure out what went wrong that this patient has to come back because that definitely utilizes a lot of healthcare resources as well as a quality of life of the patient because no one wants to come back to the hospital. So we go over those cases. So I lead the specific COPD readmission committee where we analyze every cases to see what are the opportunities of improvement, whether it's a system-based issue or whether something and provider could have helped, whether there's an issue, whether the patient medication did what I sent, did the patient receive that medication? Was there any barrier that maybe they could not afford those inhalers? Or they could afford, but they did not know the technique how to use those inhalers. Now, if they have used, maybe they did not get a proper follow-up with the primary care because of the schedule, or there was no one to call them. So that's why we have implemented transition care model, where we are aiming to call them within a 48-hour touchdown point, call them, the patient, to see whether they have received the medication, whether they have followed the schedule. So this is an initiative. So we are looking on the data and seeing what the improvements are, and we are improving the quality.
It's definitely a huge problem in hospitals, and it's amazing that you're working to improve that. I know also we talked about earlier that you have a strong background in clinical and translational research. What sparked your interest in this area, and how do you balance research along with clinical practice?
That's a great question. So I never thought of doing research when I started my medical career. However, once I completed my medical school training, I understood there are a lot of unexplored areas and there are a lot of gray areas that are still need to be answered. And who else can do that? We are the best person. So why not me diving into that field? So this led to me joining research, and with that, I tried to answer questions. Those questions came during my medical school. Like I used to see patients dying from lung cancer because they were not able to be diagnosed early, and people thought, this is a cancer, it's a late diagnosis, but what can we do differently? What are the pioneers in this field are doing differently to work on that? So all these things led to me to do further research, and then I collaborated when I was for a brief period of time at Vanderbilt University in a pulmonary critical care department. I initiated a project of combined biomarkers, basically that aimed at early detection of lung cancer, while we would take images, use artificial intelligence to have a pattern that could predict early detection, then combine with the regular test, and then create a model. So, so we worked on that, and the work is still in progress. Definitely, another aspect of research is further continuing the medical science education and your contribution to that field. So that's what sparked me my interest towards research. How I balance, uh, definitely it sometimes can get challenging when you have a heavy clinical duties. So whenever I have some spare time, reading journals, articles, thinking of ideas, then involving my residents in those ideas and designing a study. That's how I do it. And I used to do more, but now due to clinical work, I do not do much of it now, but still I continue to work on that aspect.
That's truly impressive. Do you find that your research that you do can influence the way that you approach clinical care and patient care?
Yeah, that's a great question. So definitely, uh, the research what we do will definitely impact the way in our day-to-day practice, and it has been impacting. If you see the guidelines are changing, it does change every 3 to 4 years, and the reason they are changing is because of the evidence of research, gaining new facts, uh, revisiting the old facts, seeing where we may have gone wrong, researching again. And the whole idea here, be it a translational research or be it a clinical research, is at the end of the day, am I able to move the needle, or how my practice pattern is going to change based on that research? So yeah, definitely, if you see, for example, lung cancer screening previously was between 55 to 80 years old, which has now been pushed back to 50 to 80 years old. So even that's the huge gain, because definitely we were missing folks who could have been screened early between 50 to 55.
Wow, that is really interesting. Thank you for sharing. And then moving on to your current specialty and looking at your passion for endocrinology and allergy and immunology, could you talk a little bit about how this passion of yours came to be and explain what your projects entail?
Great, absolutely. So during my interest towards allergy and immunology sparked when I started doing rotation before joining residency in allergy and immunology department. So if you look at my trend, our research was mostly based on the social media at that point of time. I'm talking about 2018, where we were analyzing trends in the Twitter, trends in the Google, that what is people perception about certain diseases like asthma, what people are thinking, because what they are searching, what are the search words there. So this way we are developing pattern strain, and then we are incorporating that into our clinical practice, and how can we what else can we do to improve that. This also helped us to understand what disinformation and misinformation was being spread along. So, and then we used to do researches on the YouTube videos. Sometimes we did. There has been one of my studies on people's perception about preparation of a colonoscopy, and there were a lot of disinformation which we were able to go over with our team, like thousands and thousands of videos, and we were able to get a statistical analysis of the same, and we were able to publish that study, which created more awareness on the people about that.
Oh, that is really interesting. Are there any advancements currently in that field of endocrinology and immunology that you're excited about, or maybe things like artificial intelligence or personalized medicine that you think will impact patient care?
Hello, hello.
Hi, can you hear me?
Yeah, I think I lost you. Can you repeat your
Okay,
question
yeah,
again?
yeah, of course. I was just asking about if you feel that there are any advancements in the field of endocrinology and immunology that you are excited about, or if you think things like artificial intelligence or personalized medicine will affect the field?
Yeah, definitely. There's been a lot of advancement in the field of endocrinology. We use when I started doing research at that time, we had this continuous glucose monitoring devices that were just coming into the picture, and a lot of the insurance companies was not paying for that. Now this has become and bread and butter of most of the outpatient people are using continuous glucose monitoring, and that has become a practice pattern. Initially, it was not, and now the how it helps is that you do not have to stick your needle to see how what is your blood sugar level. Rather, you will be getting a throughout a day of an average of how your blood sugar level looks like, and not only a day, you will see weeks, months, and that would show the patterns when your blood sugar dips, when your blood sugar goes high, and that gives more opportunity for the see what medications I need to change or go up, go down. And the beauty of this is it's not only with you that the same data can be shared with the primary care physician, and they can get an alert when, let's say, your blood sugar drops before you call the urgent care. They will be able to get in touch with you and give you some advice, and then follow the pattern. Okay, then that's how you look back and see, what, let me see what went wrong, why my blood glucose dropped. Did I take probably my insulin and I did not have the food, or my dosage might be high at this particular time of evening. So your primary care physician work with you one-on-one, find that, and solution on that. So yeah, definitely that is evolving. And not only that, in different aspects of our healthcare, artificial intelligence has a huge role, huge impact on that, especially with uh, making workflow optimization, helping with the clinical support decision, all this. And again, this is a field that is still booming. It's still work in progress. You cannot solely depend on an artificial intelligence, but at least it will give you that support or reduce your cognitive load, and so that you can focus more on your critical thinking aspect.
That's very interesting, especially thinking about the future of the field in medicine in general. Switching gears a little bit, if you look back at your journey, what's one piece of non-medical advice that you would give to current pre-med students?
uh, non I would just say, be curious. It's not just being efficient, just be curious. Don't just check boxes, always ask why, because everything every opportunity in the life gives us to understand something better about that particular thing and that system.
That is such great advice. Thank you. In your experience, would you say that there are some areas that pre-med students should focus on, or maybe some areas that you think are not as important to stress over? Maybe things like gap years, research, extracurriculars, or anything else that you're thinking?
Yeah, one thing I would, there are three things I always tell to the pre-med student. One is medicine is a privilege, so don't lose sight of that, okay? Because if you are committing to that career, you are going to have access to the most vulnerable moments of someone's life. So never take that lightly. Uh, you will feel stupid. I feel stupid every other day. That's the time you are learning. Okay, and take ownership even as a student. Uh, this is from my, if I reflecting back my journey during my medical school, I took ownership of uh, several committees, took the lead. Yeah, you will fail, but that's how you would learn. Patient is always first and always. It's about always building relationships over the time. It's not about the resume. So I would always advise the pre-medical student that this is not a sprint, it's rather a marathon. So from now, if you are committing to this career, you need to develop resilience and adaptability, because it's an ever evolving discipline, and more you are adaptable, more you are resilient, so you'd be able to navigate those uncertainties and the challenges. Then again, you are just beginning your journey. So it's utmost important that you know and you learn how do you balance your time, your mental health, and your personal growth. So definitely find time to do extracurricular activities which makes you feel better. So I'll always advise that, okay? Again, and never worry about, that you have to do this particular activities or that activity because that's related to the medical science. No, you can do very different activities. I had a medical student rotated with me, uh, was doing a script writing before, and he does great job in script writing. He was doing that. He said, I feel passionate about that, and that decompresses. So has nothing to do with medical field, but that anything it could be.
Yeah, that's great. I'm sure a lot of the students here would be very excited to hear about that advice. And seeing your experience in research, is there any advice you would give to students who are still trying to figure out what area that they'd like to research and find their passion?
Yeah, definitely. So research is a very broad term. So once you are in the field, you will know that which specialty or which particular topic you are finding interest about. So if you keep your curiosity at a high level, you'll definitely see there are questions not answered. It would be an automatic reflex that would be going, keep on searching, you'll not have answers, and then you would not understand that you'll develop an whole research idea and you'll start working on that. And if you are passionate, you will be finding the like-minded people who are equally searching those answers for those questions.
That's so good to hear. Thank you so much. I know you just touched on this briefly, but do you have any specific advice or recommendations for avoiding burnout in the field and how to balance time, mental health, and personal growth like you were mentioning earlier?
That's a great question. Definitely, in the field of medicine, there's a huge burnout. Uh, Again, that's something we are all working, but it's still the results are not that great. I'm being honest with everyone, especially fields like surgical field, critical care, emergency medicine. They have a high burnout rates, and part of that is definitely the work stress, and it's not only the work stress, it's the system expectations, because you are making every cognitive decision in duress. So first step is understanding that these are challenging. So once you understand, and so you are removing the denial phase, okay, everyone can have a burnout. Now, once you understand that, you need to set a boundary. So for me personally, once I'm done with my work hours, I will not look at any chart. I'll not look at any record. Uh, I come home and I play video games. I still am doing this since medical school. I'll do half an hour of video games. Then I read books, and those are fiction books sometimes. And then I would involved in cooking. So these are all random things I do, but definitely helps me to decompress. And in my off week, as I was mentioning, a few of the panelists here, that I go for traveling. Whenever I have an opportunity, I'll go traveling because through travel, I'm exploring lot of unexplored places, learning new cultures, new people. So at that point of time, I will, unless until it's emergency or I have to be during the work, I will go. Sometimes that's the part I sign it, and I love to do it. If my colleague is sick, I'll definitely hope my colleague can, that's an uh, collegiality has to be there, that understanding has to be there, but that helps me to not make me burn out, but I'm feeling that I'm able to help my colleague in the time of the emergency or something. So that helps me. So these are the few things. Having a better structured plan for your day, then limiting, setting up boundaries, trying, and when you are as resident, as a medical student, slowly you are climbing up the ladder, you'd be asked or offered multiple opportunities, tasks. So never overcommit. Always learn to say no. It's very difficult, but it comes with time. But always try to, if you think that that's beyond your bandwidth, it's okay to say no, then overcome it, because that will lead to burnout and definitely will compromise the quality of work. Be it your preparation for steps, be it your application, be it writing your resume, or be it your rotation. So if you think this is too much or is over the boundary, learn to say no. That small steps taken every day will help you prevent burnout.
No, that's very reassuring to hear how you can still take time for yourself and also be an amazing physician for your patients. As we approach around 40 minutes, we can go ahead and get into the case study. I think Mira can, well, she'll share her screen for the PowerPoint, and then you just let us know when you want us to switch slides.
Yeah. Mhm.
And we will, again, for the students watching, we'll still have a little bit of time at the end for questions, but if you come up with anything in the meantime, please feel free to ask in the chat and we'll get to that afterwards.
And next slide. So here I'll be presenting an atypical presentation of a common disease. This is more of understanding our day-to-day thought process and why this field is so unique. And because we work in most of the time we work in ambiguity and how we use small symptoms, connections, and get to that diagnosis. So I'll go over this case. So basically, this is one of my patient I have seen. He comes with confusion and abdominal discomfort for the last 3 days. So that's our chief complaint. So if you look at the history of present illness, this is our 68-year-old male who presents with confusion, loss of appetite, uh, and non-specific abdominal discomfort. He reported that he was not feeling well and he is not like himself for the last few days. So what I want to emphasize here is a lot of the patients would not have the clear definition of how they are feeling. So this is the common, I'm not feeling by myself, okay? 2 days prior, he experienced a low-grade fever with chills. Family members have observed changes in his behavior and episodes of forgetfulness. So it's extremely important to collect these pieces of history. Then further, if you ask him, he also notes one instance of vomiting and marked decline in appetite. One point I would like to mention here, whenever you are going over the history of present illness, be always ask an open-ended question, like what brings you to the hospital? I'll leave it there. And if you can give them your 60 seconds, they will give you a lot of information that will help you to help the patient. Now, if you look at the past medical history, has an hypertension, which is managed with one of the blood pressure medication, has COPD, has some lipid disorder. Surgical history-wise, had an hernia repair, nothing much, an appendectomy. Social history is also definitely very important. As a former truck driver, which is now retired, lives with the spouse, independent activities of daily living, smoked one pack per day for 40 years, quit 5 years ago, uh, denied any binge drinking, has some occasional alcoholic use, uh, and there is no history of illicit drug use. Heterosexual male, monogamous relationship with wife for 30 years with no history of sexually transmitted infection or high-risk sexual behavior. Now, then once we have the detailed history of past medical, past surgical, we go over the review of system. So general, he definitely has abdominal pain, so the appetite is decreased, has some subjective fever, no initial cough or dyspnea, but said that he's having short of breath on the day 2. Right upper quadrant abdominal discomfort, nausea, one episode of vomiting, but there was no diarrhea. Cardiovascular wise, unremarkable. Genitourinary wise, unremarkable. Hematologic wise, unremarkable. Skin, there was no rash or jaundice. Musculoskeletal wise, body aches, but no focal joint pain or swelling. Vital signs when he was brought to the emergency department, then as I was mentioning, we get this call, has some low-grade TEM 99.5, heart rate is 110, respiratory rate 32 beats per minute, blood pressure mildly on the lower side, 100/60. There is no jaundice, but he definitely has a dry mucous membrane. There is no jugular venous distension. Respiratory rate definitely the respiratory rate is very high and is using the other muscles of respiration. So he is struggling with breathing. Abdomen wise, there is mild right upper quadrant tenderness when we are examining him. Other than that, neurologic wise, we did notice some tremor in his hand, otherwise no rash. Things what I wanted to mention in general that this labored breathing and he appears ill and fatigued. So that's something to note about. So these are the labs we got. So we did a blood gas analysis where we see that the patient is breathing so fast that he's losing a lot of carbon dioxide. Uh, his white blood cells counts are high, denoting infection. His ammonias are high. That also can cause confusion. Prolactin is one of the inflammatory marker for lung infection that is high. So at this point, we would see what are our differentials, right? So sepsis, as we know, is our top differential. Given he has history, he's showing signs and symptoms of increased respiratory rate, difficulty breathing, fever, tachycardia, there's elevated WBC, inflammatory markers are elevated, which strongly suggests that this patient is having an infection called sepsis. So sepsis has a high mortality rate of 40% despite the treatment. Also, his liver functions are elevated, so acute liver failure is another differential. So this point, we are creating our broad differentials and then we'll narrow them out. So the reason we do it that because we want to prevent anchoring bias, we do not want to focus on one particular diagnosis and miss others. So as you see, we have made 7 broad differential diagnoses. One is your acute liver failure, acute hypoxic respiratory failure because patient is having difficulty breathing, has a respirator 32. Patient is also on nasal cannula, hepatic encephalopathy, a patient has an electrolyte imbalances, hyponatremia with low sodium. Patient also can have a drug-induced liver injury. We do not know. Could be viral hepatitis. So all these are broad differential. Next slide. Yeah. Now I'm going to go over the day one, what we did. So as I mentioned, we get this information. We discuss with our emergency physician. We admit the patient on our floor. Okay. And then we look at we do this imaging. We did an initial workup. A chest X-ray showed patient does have some consolidation, which is suggestive of pneumonia again. Some liver enzymes elevated, white blood cells count are high. So we had to start them on antibiotics, fluids, and then we admit the patient. So patient is definitely sick because he meets sepsis criteria. And patient also noted to have some mild confusion, which would be attributed to the infection-related delirium. Day two, so given patient has this, patient was very sick, patient started deteriorating. So this is something you would be seeing a lot during your day-to-day practice. Sometimes we may not predict what would be your day two, but we did have a lot of early warning signs and we knew this patient was sick. So now, initially patient was struggling to breathe. Now patient saturation has been dropping down to 88% on day two. Now he's requiring 4-liter nasal cannula. Her respiratory rate still high, is getting confused. Lactic acid is going up, liver enzymes are going up. Then we do another blood gas and now we diagnose him with an acute respiratory distress syndrome. Now, this is another transition point. Now, as a hospitalist, now I'll be consulting our ICU team. So this patient has now become very complicated. It's a threat to his life. So we immediately consult ICU. So the coordination has to be very efficient and fast here. I'll present this case briefly to our ICU attending, and then we'll transfer the patient. Now they was started on a high flow nasal oxygen, and patient was breathing at 100%. However, patient still struggling to breathe and was getting so tired and fatigued that we had to put him on a mechanical ventilation. We started on broad spectrum antibiotic. Most likely the cause of liver injury was sepsis, which caused decreased blood flow to the organ, and because organ needs a lot of blood, so the organs underwent damage. Could it be drug related? Possibly. So there are a lot of possibilities in our medicine, but we categorize them from most likely to less likely. And then the patient was started on inaspiratocysteine just because we still were thinking it could be probably an acetaminophen toxicity, and then vitamin K because liver functions was getting deranged. Day 3, patient further gets worse. Patient is now in a multi-organ failure. If you see the bilirubin is going high, so as INR, his kidney function has been also getting worse. So he's now having a multi-organ failure. Okay. Now we come to our final diagnosis. That patient does have an acute liver failure with probable ischemic hepatitis plus ARDS. From where did the ARDS come? Most likely from the sepsis due to pneumonia. So if you see, these are all complex diagnoses, but we are breaking down into simple diagnosis step by step. So as a hospitalist, if you see, we have this multidisciplinary consults. As I was speaking, we interact with our hepatology team, critical care, nephrology. There was a discussion of a liver transplant candidacy. CRT initiated preemptively. That is, we do a continuous dialysis. If the CRT means to do a dialysis throughout 24 hours because we need to clear those toxins from the system. In the slide. Okay. So this was a brief case. What I wanted to highlight here is that if I'm talking about an internal medicine, is the foundation of the adult medical care. So internists are the detectives of the medicine. If you have seen that initially he just came, that he was not just feeling himself. But given that we allowed an open-ended question, we were able to get some information that he was behaving strangely. He was probably having altered mental status at home, along with some low-grade fever. So all these things we are putting constellation of the symptoms. So this makes us think deeply and just solve this complex puzzles. Okay, and then we are managing like as simple as it could be common cold to those rarest of the mysterious disease or the complicated disease as we are discussing in this case. Again, whether it's managing chronic conditions like diabetes or hypertension or diagnosed patient is vague but serious symptoms, internists are the ones that people count on. So we do this holistic management. Uh, that's how we differ from critical care intensivists because if you look at the critical care, they do take decisions definitely in duress. They have a lot of variability, a lot of unpredictability. For us, we are the ones who will be admitting, being with the patient throughout their hospital course. Again, as I always emphasize, it's about the why behind the illness, not just treating the symptom, but understanding the whole picture. That's why I was able to break down all this diagnosis, starting from sepsis, how that sepsis happened due to pneumonia, and that complicated to have an further bad lung disease called acute respiratory distress syndrome that further led to multiple organ failure. Next slide. So this I wanted to show a path of becoming a hospitalist if you are interested, as we have a lot of cohorts in our panel today. So pre-maturant, MCAT, you do your medical school, you take your years summary tape, you do your internal medicine, residency 3 years, and this would be your base to think of your future trajectory because you'd be exposed to inpatient rotation, what I'm doing. You'll be also exposed to outpatient rotation, where we'll be managing chronic conditions, preventive aspects. You'll be also doing the ICU. You'll be getting a glimpse of how unpredictable ICU is, how dynamic the system is. Then we'll do night floats, like you'd be doing. So the management in the night is very different as the day because you're putting out fires there. So your thought process entirely changes there. So you'd be changing that. Then, if you decide you become a hospitalist who is focusing on not only adult care, you have an opportunity of teaching, leadership, quality initiative, admin roles as well. This is another slide I made. Again, our transition is from prevention, complex disease management. Interest, as I said, will act as a detective of the medicine, where you are involving deep thinking, understanding the root cause of the illness. It's not only on the tip of the iceberg, but you are knowing what led to all this situation. Then we go beyond the symptom relief. We focus on comprehensive care. We do not just treat the symptoms, we treat the illness. So this is something I want, if you are thinking of a career in medicine, be it a surgery, be it radiology, be it ICU, or be it any other field, do not just treat the symptoms, thinking the whole way the illness. Okay, so that requires broad medical knowledge and strong clinical reasoning, and you will have this whole journey that will fill you with that, and it is fulfilling. Next slide, please. So this I wanted to show what is our day-to-day work. I probably have discussed, but just gonna give a glimpse. So outpatient and inpatient. Okay, so I'll just give a glimpse. In the outpatient, with the chronic conditions like diabetes, hypertension, high cholesterol, asthma, arthritis. So unique thing about our primary care is you'll be treating them for years and years. So it'll be more like a family members to them. You will be giving them a medication. You'll be following them throughout every 6 months, 1 year. That's what again means a longitudinal care. You continue to follow them, how they evolve in disease. It's fulfilling to see if you can help them prevent certain complications from the disease because of your proper counseling, proper dosing, proper coordination with the care. You are able to prevent them to come to the hospital. So that's definitely a great feeling if someone is thinking of a career like a outpatient. Definitely quality of life. You will have your fixed hours, perform preventive care, as I mentioned. You will manage multiple medication, coordinate with the team, counsel patients on their lifestyle, nutrition, risk factors. So they'll have more trust on you as compared to any other specialty. And then you collaborate whenever you need with cardiology, endocrinology, if you need help from the surgery, but you are the primary who will be coordinating. Again, what does the internist do day to day? Hospitalist role, as I discussed, we admit and care for acutely ill patient, make fast but thoughtful decisions on complex cases. We coordinate care with ICU, consultant, nurses, social workers, as I discussed. We lead these multidisciplinary rounds and family meetings, teach medical students and residents if we are in the academic center. Why internists matter to the society? So chronic disease experts. So internists are on the front line of managing chronic disease epidemic, helping people live longer, healthier lives. Health system backbone, public health champions, because you are the ones who are preventing complications and promoting wellness at population level. So you are not just touching a particular patient, but you are catering the whole community. Then you are also educators. You are shaping the teaching, conducting research, leading hospitals, healthcare systems. Next slide. So why pre-med should consider internal medicine? Again, deep connections with patient over the time. Internal medicine definitely gives you that. Dream of keeping your options open. This is the most uh, favorite point of me, that if you're doing a residency in internal medicine, it gives you open doors to your fellowship in cardiology, gastroenterology, infectious disease, oncology, critical care, etc. If you are curious about the health system, if you want to know how this health policy works, how the quality improvement works, or how it is affecting the global health, internists lead those initiatives. Future opportunities after internal medicine residency. As I said, there's a wide scope of practice from outpatient primary care to critical inpatient care and subspecialty. Fellowship training, internist either you can do in community hospitals, academic centers, rural health, or internal medicine. You can be a leader and administrative roles like healthcare systems, policies. You can drive policies. You have opportunities in medical education, mentoring, improvement in the involvement in the clinical research, quality improvement, population health. Now the new era is telemedicine, then artificial intelligence in healthcare, digital health innovation. A lot of people does clinical informatics. Internists are essential to public health, health equity, and preventive care initiatives. Yeah, so same as I discussed. Next slide. Yeah. So again, as I said, broader career flexibility of any specialist from generalist to super specialist you can become. You can from outpatient to the global health. You have 20 more than 20 fields of specialty if you are thinking. Then the emerging specialties like palliative care, addiction medicine, obesity medicine, and geriatric, leadership, opportunity in research, ability to combine clinical care with teaching, health tech innovation. Yeah, next slide. Thank you. Uh, I'm more than happy to take any question.
Well, thank you so much for presenting that and giving us a case study as well. It's really very helpful for understanding what we would actually see in a clinical setting. Does anyone have any questions for Dr. Mahapatra, whether that be in general, or you can even ask more about the case study if there was something you were intrigued by?
I'm kind of curious about your like 7 on, 7 off schedule. Is that something that you get to decide, or how does scheduling work in general in the
Yeah.
medical field?
That's a good question. So this has been happening for last couple of decades. So as an hospitalist, it depends on which type of setting you are working. So if I have to break it down, our setup is community hospital with an academic affiliation. So in these settings, you can work your 7 days. So you're on 12 hours a day. So you are 7 a.m. to 7 p.m. And then you are done with those 7 days and you are off in the next 7 days. So this is more geared towards work-life balance. And in certain academic centers, they have a system like regular Monday to Friday. And then every 4 to 6 weeks, you will be working on the weekend. So it depends what kind of schedule you would like prefer. So you do have options of choosing based on the hospital setting. Even certain academic centers are also now opting the 7 on and 7 off schedule as well. So this gives you more flexibility, better planning, better work-life balance.
Hey, I know we briefly mentioned about gap years. Can you talk a little bit more about what your thoughts are with taking a gap year, and if you were to take one, what you should really do with it to maximize your time?
Yeah, I think that's a great question. Definitely, if you think that you'd be wanting to take a gap year, definitely try during that time exploring that uh, if because this is a long journey. You have to do your pre-med school, your undergrad, med, and then internal medicine residency. That's 3 years. But if you are planning to do any surgery residency, that's 5 years. If you are planning for any further like cardiothoracic, they are way longer. So question comes that would you be able to dedicate that amount of time, or do you have that interest? So these are all the things that you'd be exploring during the time of your gap year thinking. And if you are interested, definitely uh, go over, study some of those. There are a lot of books as well about the career guidance, how you would be navigating it depends on which stage you are. So that definitely helps. And if you answers your question, okay, this is the amount of year I'm investing. Again, this comes that how much you would like to dedicate yourself to the service of the humanity. Okay. Again, there is different ways to serve humanity. Medicine is just one way. Uh, from my background, no one has been in the medical field, but they are also serving in different capacities. So it's again, what is your calling? So I think gap year definitely helps you understand your calling. And that way, if you join, you won't feel the burden of the studies. If that answers your question, Tyler.
And I know you mentioned previously like working a lot or advocating for international medical graduates. Can you just talk a little bit about your role with that and why that's something you're super passionate about?
Absolutely. So being myself as an international medical graduate, that's something is very near and dear to me. If you look at my journey, when I came here in this country, this was definitely a different cultural uh, avenue to me. At that time, navigating USMLE journeys, understanding the exam pattern, taking them, the procedures, the nuances specifically, and going through that and getting to the residency was very unique and a lot of learning opportunities down the road. So what I believe is uh, people are applying for the residency throughout the world. They are all international medical graduates, but there is still that there is no unified way that those folks can see, or there is no particular guideline how they would proceed. So my goal here, once I wanted to reach back to my community, people who are trying to come here and help them navigate the resources, be it like in getting an observership, how do they search, or how to write a personal statement. So how to write an resume or CV, because in a lot of the places, these are not mandatory in different parts of the world. So this is something they'll be learning. And in order to be at the cutting edge, they need to learn faster. And so this is my way to create those resources, help them. As a matter of fact, I am now the chair of International Medical Graduate Committee with the ACP South Carolina chapter. So I'm leading them with a lot of residents throughout South Carolina. We are in the process of creating database, and if you see again the landscape of international medical graduates, the statistics, 25% of the US physicians are international medical graduates. So there's a huge proportion of the people are there, but they're scattered. So our goal is to kind of help them navigate this process, ease the transition.
So that was kind of gonna be my follow-up question as well. Like, I've noticed recently that there's a large portion of international medical graduates. So when they are here and they do become doctors, like, how does that work in a healthcare setting? Are there any like barriers? How does everyone work together? What does that look like?
So when we talk about the international medical graduate, there are two types we broadly divide. So they're the broad classification. One is what you call as a non-US international medical graduates. That means they are requiring visa at different capacity. And there is US medical international medical graduates who are US citizens, but they have done the medical school, either there are some Caribbean medical school or any other parts of the world. So for the non-US international medical graduate, there are two kinds of visa category. One is H-1B, one is J-1 visa. So with the J-1 visa, once you are done with your residency, so you have options. Either you want to do fellowship, you can definitely do, but at the end, you have to do serve in the underserved area for majority of the countries in the world, not all, for 3 years. That way, they will give you a work visa. So this is a very gray area. So our goal here is also to provide more resources. What are those underserved areas where they can apply, how they can apply, when they need to search for this job? Because in order for the transitions to happen, mostly with the visa, it definitely takes 8 months to years. So they might be late in the career if they're searching their job, be it at a fellowship, be at a residency, uh, let's say 2 months before graduation. So that will be delayed start. And sometimes because of visa issue, they might have to go back to their country because they do not have the visa. So our goal here again as an international medical graduate to educate the people that to search jobs early, where to search, how do you navigate the program, how do you do a contract negotiation, all these steps and so forth.
So as a hospitalist, like how does that collaborative aspect work when you're working with like international or other international doctors? Like at the end of the journey when you're in a hospital setting, How can you kind of explain how the like collaborative aspect of working
Yeah,
with people from different cultures looks like?
absolutely. So this I do as in voluntarily, helping the international medical graduates. So this is my passion, my initiative towards them. So in our hospital, we have a lot of international graduates at different capacities. Some are working, some are residents. So definitely within us, we do keep educate people about the future needs, like what they would to do to navigate the visa process, how they will do it. But apart from that, we try to spread messages. I'm in certain groups. They organize webinars to educate the mass. Again, people are scattered all over. So it's just trying to find the people, spreading the information. So this is most of the time I'm doing during my off days. This is just me giving back to the society.
I had a quick question before we wrap up. Do you think that there's any specific challenges about your specialty, your field, that you find that like you come across often, or any misconceptions?
So definitely every field has its own challenges. Definitely misconceptions are there. So for us, the challenges is definitely balancing your clinical duties with your academic duties and research. So definitely with a limited time frame, that definitely becomes challenging because is rounds are dynamic and multifaceted. So morning time when you typically begin the round, you are asking patient at the same time. Once you are the resident, you need to teach them as well. So we try to find a time. Sometimes it's not picture perfect. Sometimes we'll be just impatient if it's a bad day, and it's most like an on-the-job training. But whenever we have time, we try to teach them because their education is also of paramount importance to us, so that we make sure that they are not lagging in the education. We are utilizing their time as well. So that's definitely one, because the demands of the patient load, academic responsibilities together needs to be balanced. So that's definitely a challenge we are all working on. Okay. Also, people think that as an hospitalist, your job is only to do an inpatient care. But throughout my slide, if you have seen, it's not only an inpatient care, it's way broader. We look at the contribution, we contribute to the medical education, research, development of hospital protocols, which enhances the safety and quality of care, and we do active participation in transition of care. So just again to reiterate, it's not only that we manage in the inpatient, we also take an active role in the quality improvement system, in development of the patient safety and quality care.
Thank you. Does anyone have any other questions? And if not, Dr. Mahapatra, is there anything else you'd like to share with the group, keeping in mind that most of us are pre-med students looking into going to the medical field?
I can say that it's an exciting field, it's an ever-changing field. We need a lot of you. We are still struggling with the shortage of physicians. Do consider this field. Anything, questions that might rise, if you have a doubt choosing this field, feel free to reach me. I'm more than happy to help you guys. And I can say you, if you love complex puzzles, if you love complexities, if you love uniqueness, this field will not disappoint you.
Okay, well, thank you so much again, Dr. Mahapatra, for being here with us. I know I've learned so much from our time together, and I really appreciate your willingness to share your experiences, advice, and everything you've learned throughout your medical journey. To everyone who has joined us, thank you so much for being part of this conversation. If you have any additional questions, feel free to submit them on our website as we showed earlier in the webinar, and we'll make sure that they get answered by Dr. Mahapatra by the end of the month.
And as we mentioned earlier, a recording of this webinar will be available on our YouTube channel if you missed anything or want to go back to it. And you can also catch the podcast episode soon. As always, feel free to reach out to Mira, myself, Sham, or any of the contacts listed on the website. Again, as Dr. Mahapatra mentioned so graciously, if you have questions for him, please feel free to reach out. You can also contact Sham or the PhysiLink Gmail, and we can connect you with him as well if you don't want to ask the questions on the website. And with that being said, thank you again for joining us. Thank you, Dr. Mahapatra, for being here, and we hope you all have a wonderful evening.